The idea behind public safety is that it's the job of the public safety system to prevent crime in the community and to bring offenders to justice. So the ultimate goal is to reduce crime. You know, when you're thinking about public health, you're fundamentally thinking about improving health outcomes, so reducing disease, improving mental health, reducing substance use. And the justice system actually has mandates to do both of those things, to both help the public be safer and reduce crime, but also to improve health. It's constitutionally mandated. And I think people tend not to realize how many people in the United States go through the justice system every year. It's about 15 million. About 11 million are in pretrial jail detention. They come in and out quickly. Maybe they're there for a few days, a few weeks, but then they're back in the community. But about 2/3 of those, you know, who come into the jail have substance use disorders. More than half have had mental health disorders. A lot of them are at risk for suicide, at risk for sexually transmitted infections, at risk for, you know, being victims of domestic violence. They're at risk for a lot of things. And so the jail becomes this place where a lot of the folks at high risk for health problems come, and therefore, you know, it can be used in this public health kind of way to identify and intervene with people at risk in the larger population. So interpersonal psychotherapy, IPT, is one of the two sort of frontline psychosocial or counseling interventions for major depression. It's IPT and cognitive behavioral therapy, CBT. In one of the big early studies, IPT was actually found to be better for severe depression. So it's a very strong evidence-based treatment for major depression. I love it for justice-involved populations because I think the themes addressed in it are universal. What happens when you do IPT for depression as a clinician, I would try to identify when the current episode of depression started and then talk to the person about things going on in their life around that time. And when I'm listening for that, I'm listening in 4 major categories. The first is grief or death of somebody close to them. And people in the justice system have a lot of violent and illness-related deaths, other deaths of people around them. The second thing I'm listening for is major life changes, so things like getting a partner, losing rights to children, becoming incarcerated, losing a job, getting a job. And there's a lot of life instability that happens around incarceration. The third thing I'm listening for are conflicts with important people in their lives, partners, children, parents. And the fourth thing I'm listening for is social isolation. And then IPT will set goals in those areas to sort of address those triggers for depression. And the reason I like it for justice-involved populations, well, first, it's been shown in 2 clinical trials now to be effective for reducing depression in justice-involved populations. I like it because I think the themes are universal of grief, loss and change, isolation and conflicts with important people. It's been shown to work in Uganda, you know, in rural Uganda and all around the world. I think it's more adaptable across cultures than maybe some other US therapies that require you to think about thinking. It's not really like that. It's about your relationships with other people. And I think it's an especially good fit and works well in the prisons because these are the issues that both women and men prisoners worry about at night. You know, are my kids okay? Is my spouse going to wait for me or my partner? You know, I'm fighting with my mom who has custody of my kids. Am I going to lose custody of my kids? I mean, these are the things that keep people up at night. And so, you know, it's good to do a lot of behavioral interventions in the prison in terms of changing behavior, but you know, for people who are depressed and having mental health problems, I think it also really helps to address some of these major life issues that pull on their hearts. There's just so much more need than there are providers. You know, a jail that admits 13,000 people a year might have, you know, money appropriated by the county for 1 day a week of a psychiatrist. You know, even fairly well-funded states with low incarceration rates, you know, may only have a handful of social workers for the whole state. And, you know, often people don't get counseling, or if they do, it's by, you know, bachelor's level line staff who don't necessarily have mental health training. So I think it's just the amount of need in the system and relative to the resources in the system, that provide challenges to implementation. So one of the things I like about IPT is that when they did the trial in rural Uganda, they were actually able to train providers with no particular educational background or mental health experience at all to do IPT effectively, and found it was effective in these rural Ugandan communities. So in a couple of my trials, I've been able to take bachelor's level counselors who are not counselors in the sense of having mental health training, but they might be substance use counselors or just sort of folks who help arrange services for people, and train them to do IPT and to do it with good fidelity. It took more supervision and more training, and I'm still evaluating the cost effectiveness of doing that, but we have evidence to show in other settings that IPT is open to task shifting kind of approaches where you basically train people without mental health training and they can do it well. The Spirit trial started because the National Institute of Mental Health is working on a zero suicide initiative with a lot of other suicide related agencies. And they were looking through the literature about suicide, and someone in there found that about half or almost half of people who commit suicide aren't in any kind of mental health treatment. So they were trying to figure out, where are these people? And one of the places they are is the justice system. And Dr. Lauren Weinstock and I lead this Spirit study together. And Dr. Weinstock went through the National Violent Death Registry and found that 10% of suicides with known causes occur in the context of a recent criminal or legal stressor, for example, arrest and jail detention. I mean, if you think about the jail, you have more than half of people with mental health problems, 2/3 with addiction, and usually people don't get arrested when things are going great in their life, right? So you have a high-risk population at a vulnerable moment, and so you get a lot of people at risk for suicide. And so what Spirit does is intervenes with folks in pre-trial jail detention. This is where you go when you're arrested, picked up, typically held for a few days. You may be bonded out. You might get charged, but most people are bailed out or sent to probation. And that's 11 million people a year. And we're trying to see if a brief suicide prevention intervention that's been found to be really effective in emergency departments, it's called a safety planning intervention, can reduce suicides and suicide attempts and suicide thoughts in the year after release from jail. And if the intervention is as effective in the jail, in that year after jail, as it is in emergency departments, it can reduce all US suicides by 5 to 9%. And what it does is it brings a community mental health counselor into the jail to do a safety plan, and then the counselor follows up by phone as the person goes into the community to try to keep them safe and link them to mental health services.